Minnesota has one of the best known state STEMI systems in the entire country. Could you tell me how it got started?
Yeah, Tom, it's really an interesting thing. Really back in 2002, it was pretty clear at that time that primary PCI was the ideal strategy of reperfusion if it could be done in a timely manner. The problem, of course, is availability, in that a lot of hospitals in the United States don't have cath labs. And then the point is, can you transfer those? So what we did is we really started off, we knew that there was early data from the DYNAMI trial that showed that transfer for PCI was also better. And so Minnesota is a relatively rural state with several large centers, population centers, a moderate number of cath labs, but then really a lot of small to mid-sized towns that don't have and won't have cath labs. So we thought really that expanding or increasing timely access to PCI, that what we would do is set up a network of hospitals, non-PCI hospitals. When a patient came in, would have a standardized approach to treat that patient with the appropriate adjunctive medications and then transfer them for primary PCI. So we started in 2002 with a hospital called Waconia, Ridgeview Medical Center. And my partner, Dave Larson, who is an emergency room physician in Waconia, was doing a Bush Fellowship. And it worked amazingly well. We found very early on that we could dramatically decrease time to treatments. It was very clear early on that by having PCI availability and doing it in a timely access, that you were going to improve outcomes. So we very quickly then expanded this to more hospitals and more hospitals. So finally we had about 12 to 15 hospitals within a 60-mile radius of Minneapolis. And that was so successful that then we said, okay, we need to expand it out even further, and can we go further? So we took a second group, and that was from 60 to 210 miles away. And again, we gradually added them. You didn't do them all at the same time. Involves a lot of teaching and training to really, including the emergency room physicians, the paramedics, the primary care physicians, really the whole local community. So to develop a system so that for that city then has a way to handle the patients who come in with ST elevation in mind.
So how far away does a patient have to be in order to get thrombolytic therapy first prior to PCI in your system, assuming no contraindications?
Yeah, so what we did is really, as we do, it's a PCI-based system. And there's a standardized protocol. Really, every point of it is standardized for all the system. The system now includes about 35 hospitals and 10 clinics throughout Minnesota and western Wisconsin. And those patients, when they present to those hospitals with an ST elevation in mind, are treated initially, stabilized, and then transferred for primary PCI. Once you get, and we know the guidelines, even the new ACC-AHA guidelines is for patients transferred, both European and AHA guidelines are greater than 120 minutes, you should do some kind of lysis. There's also since then great data that says a pharmacoinvasive approach is effective, combining the two. So what we chose to do, and this shouldn't be the focus of what we want to talk about, but for those patients that are going to be greater than 120 minutes, they receive a reduced dose of fibrinolytic followed by PCI as well. But I think really the success is what we've shown from the program is by having standardized protocol, an individualized transfer plan for that community and that hospital, that you can effectively transfer patients up to distances 210 miles away with outcomes that are identical for those patients who present to the PCI hospital itself. And so really what we've been able to do and show effectively is that you can expand access to timely access to primary PCI, which we know will make a difference. And in fact, I think that the reason why it's been so gratifying is that the outcomes have been so amazing. But really the impact of having a standardized protocol and a system of care, it's really beyond time to treatment. Because by having a standardized protocol in place, you have all of the patients, close to 99% of the patients get the appropriate drugs on admission and the appropriate drugs on discharge. Get follow-up, smoking cessation, cardiac rehab. Really, the point is a system of care that very closely involves EMS, the non-PCI center, and the PCI center. And not just on the way in, but also when you go back, because all these patients go back to their local communities.